Okay. Well, thank you. So thanks for the organisers for inviting me to speak today. I am not in any way an addiction specialist. I'm still, amongst the many things that I do, I'm still actually a practising geriatrician and see a lot of older people. Anyone who's ever worked with me will know that I'm a very avid deprescriber, which is something that we geriatricians espouse to be. So I'm going to take a slightly different approach because I'm not coming from an addiction background. I'm coming really from a geriatrician from a perspective of someone who really practices in late life. And if I was to put any temper on some of the enthusiasm about this problem, a lot of the people that you're talking about I wouldn't even consider old. Between 50 and 65 really isn't old. Particularly as I approach 50, I think that's clearly not old. The people I see typically are in their mid-80s and 90s. And I think one of the things we just have to be clear is that the pattern of use of drugs and of abuse and misuse of drugs varies greatly across that age spectrum. However, as I will point out as we go on, there are quite significant issues related to drug dependency or difficulty getting off drugs, which is relevant. So I'm going to talk a bit about physiological ageing, frailty. I'm going to talk a lot about medication risk in older people and some of the latest science, some of which is Australian, not my research, but some very, very good research done by Sarah Hilmer in Sydney, and that relates to anticholinergic and sedative drug burden. I'm going to talk about some other problems and talk about a little bit at the end about, I'm not going to talk so much about cascade prescribing or under-prescribing today, but I'm going to talk about some issues related to drug dependency that I see. So, look, we've already heard from Brian a little bit. We can describe how older people change. We do know we get a lower lean body mass. We get an altered volume of distribution for medications because we have more fat and less muscle as we age, which is in fact really a lifestyle choice. Most of that is driven by inactivity, as well as some hormonal changes with ageing. We know that kidney function deteriorates and we know that liver function generally deteriorates, but kidney function particularly deteriorates. So the whole metabolism of drugs, the whole volume of distribution of drugs, the whole pharmacokinetics changes. And that's all very interesting, but it's actually not as helpful as you might think, because for many people, apart from modifying drug doses and renal failure, it actually has very little bedside impact. But one of the things is that, and I'm talking about this idea of frailty, is what actually is physiological ageing. It's actually a very, very difficult thing to define, and everyone ages differently, and where we are now in terms of thinking about ageing is that there's a much greater contribution of environmental factors than there is of inbuilt genetic factors. So if you go back 50 years ago, everyone was searching for the magic food, substance or otherwise that would stop us ageing, the kind of philosopher's stone. Sadly, the only philosopher's stone we found is good eating and regular exercise, which is advice that you've probably received from many doctors and we all completely ignore. Or at least feel guilty about not doing it. I guess that's okay. We do know that everyone's organ function gradually deteriorates with age, and we also know the other thing that's really important and really self-evident is that the older you get, the more likely you are to have disease. So as we age, we tend to accumulate risks for diseases, then we get diseases, then we die. That's sort of how life works. And this is a little morbid, I'm sorry. Diseases do lead us to becoming disabled. So this is something that interests geriatricians greatly, is that prior to death we usually have a period of disability. The goal of geriatric medicine is to compress that morbidity, compress that disability, and so that you're kind of partying 89, dead 90 on your 90th birthday. It's actually harder to achieve than you might imagine. Just to give some very brief summaries, and I won't dwell on these, your exercise performance reduces, we are less fit as we get older, our maximum exercise performance, blood pressure changes. We know that muscle changes, and I will talk a little bit about this a little bit further on. One of the really important interactions between medication and our health is around the maintenance of our muscle strength and muscle mass. And we talk a lot about in ageing now about the issue of something we call sarcopenia, which is about a loss of muscle mass and function as we age, and pharmacology has a clear impact in that. And we do know that this loss of muscle strength over age, it's a really important part of what maintains our independence and maintains our ability to do things as we age. So the brain and the skeletal muscle system are probably the most important organs to look after as we get older. So one of the things this concept of what is frailty, and it's a concept that we often talk about as something called homeostenosis. So for those of you who've done physiology ever will know of something called homeostasis. That is where the body has, all our organ systems have a tendency to try to correct back to a norm. So if our blood pressure drops, we have compensatory mechanisms that will return our blood pressure to normal. And when you're young, those compensatory mechanisms have a wide gain. That is, they can operate over quite a broad physiological range and bring you back to normal. So if you get dehydrated because you've got gastro when you're 25, you'll retain water, your kidneys will concentrate water much more effectively than when you're 95. And so what we have is this idea of homeostenosis. And what frailty is the fact that our physiological range over which we can perform becomes narrowed. And that means any particular insult is likely to tip you over the edge into full physiological decompensation. So what that means is, whilst homeostasis is about negative feedback loops which restore us to normality, once you exceed the capacity or gain of that system, you tend to go into a downward spiral. So that's one of the reasons why we die, is because of this issue that our ability to maintain physiological normality reduces, or the range over which we can do it. And one of the things that pushes people out of that realms of physiological normality is pharmacological treatment, or the adverse effects of drugs. And we know as we age, we look at a lot of these medicines, and the opioids are a very good example of this, is that the therapeutic window narrows greatly as we age. That is, the dose at which you get benefit and the dose at which you get harm get closer and closer. And it's very common for me to treat people with pain, and apparently I'm doing the wrong thing, because I do treat a lot of older people with opioids for their pain, because the fascinating thing looking at those slides is over that time we've had enormous education from the pain point of view that we should not be ignoring pain in older people, and we should be treating it. And I suspect that might have something to do with the increase in prescription. Whether we're using the right opioids is a separate question. But one of the things we commonly find when we treat pain in older people is that they are vomiting and getting pain relief at the same time, and that's really not good. In younger people it is easier. You get a broader therapeutic window. So just to summarise this is the secret of life, and this is absolute gold. We're born. The good news, and most people in the room will have peaked already. We say 30. It's a bit variable. Men peak a little earlier, women peak a little later, it's said to be. We then basically face a decline of ability. Hopefully most of us will have a period of plateau, somewhere between 30 and 60, that we actually keep a reasonable level of function, but mostly we deteriorate a little bit. Then what happens is, through lifestyle and disease, become frail. So we actually can't do much as we used to do before. We can still do it, but we start to become only just being able to walk, only just being able to shower, and we start to get diseases because of our lifestyle choices, the environment we live in, and so forth. Then we get disabled, and then we die. That's really life in a thing. The good news is, of course, is that sudden death may intervene at any moment. And this is important, and it is relevant, and I'll explain why it's relevant to prescribing in a minute. And one of the really big changes in considering this, and I think this is relevant too about the use of opioids and drugs in the very late life, is where you are on your life's journey. And we talk a lot about these end-of-life trajectories now. And this is from this paper here, and this is a really important clinical concept. So if we consider a cancer death, which is the typical death, for example, and this comes from the palliative care literature, I should add. You have cancer, along here, you cough up a bit of blood, and all of a sudden you've found you've got disseminated small cell cancer, and you go from being really able, through a rapid deterioration ability, to death over a very short period of time. And we all conceptualise that form of death really easily. This is still a very relevant form of death to the population, but we're also seeing a lot of people die from heart and lung failure. And we conceptualise, you can show very high mortalities of people with severe heart failure. And one of the problems is that they can be as bad as cancer, but their rate of loss of function is often punctuated by these dips down where your heart failure might get worse, and then eventually you'll reach a tipping point and you'll have a rapid decline to death. Now, the reason why this is relevant to prescribing is your prescribing at this point might be about maintaining, your goal of treatment might be about keeping people living longer. But if you've reached this tipping point, your goal of treatment is going to be palliation. And so you're going to use a whole different set of prescribing and investigation things. The form of death, and it was in the newspaper yesterday, the second commonest cause of death is now dementia. And this is where life for geriatricians gets really complicated, because in fact, in both of these forms of death and these forms of trajectories in life, we kind of reach a point where it's obvious the end is coming. Dementia, you kind of just gradually fade away. And whilst you get very low levels of functioning prior to death, your ability to predict that last phase of life and when to change from aggressive to palliative treatment becomes much more complicated. It's much more a grey zone. And that's one of the reasons why we struggle with prescribing this age group. We struggle with over-intervening and under-intervening because we can't quite judge where someone is in their life spectrum. But this is a really important way of considering how you prescribe and treat older people. Now, we'll talk about polypharmacy or poly-anticholinergic. It's sort of de rigueur amongst geriatric medicine, and by the way, this is a slide, it's an apocryphal slide for one of my colleagues who's retired now, but this is one supply of medication that someone had in their house when they went and pulled it all out. There's a box of Laxets in there somewhere, because I'm sure at least one of those drugs would have been constipating you. There's the Laxets for those of you. You know, we've always taught, and in fact everyone talks about it, you know, oh, you take too many drugs, it's got to be bad for you. The complexity we've got is that if you actually look, and I'm not going to talk about a lot of this today, but if you actually look at the biggest harm we cause with medicines is actually under-treatment in older people. So older people are systematically denied beta blockers for heart failure, which is a highly effective treatment. So we've got this tension of, we've got effective treatments, and we've got too many other treatments, and is simply saying too many drugs a bad thing? And to be honest, the evidence of harm of too many drugs is actually fairly limited. Basically, drugs, the good, the bad, and the ugly. I think we should emphasise that prescribing has made people's lives, it can make people's lives better, let's get that to be fair. You know, there are lots of advantages. You know, mental health, we don't have lock-up psychiatric facilities, or we sort of do, but we don't have them as much as we did because now we can treat schizophrenia. We can control symptoms, for example. There's been great advantages in psychopharmacology and in other forms of pharmacology. We do know, however, that about 10 to 18% of hospitalisations are medication related. There's these criteria of inappropriate prescribing. The Beers criteria, an American thing, they're a bit outdated, but they're still one of the gold standards. About 20% of older adults are taking a probably inappropriate, and 3% are definitely contraindicated medication. So what is the problem? Is it too many, the wrong dose, or too few? And it may actually be all of those. As I say, we traditionally teach that polypharmacy is bad, but some drugs worse than others. That question really needs to be answered. To be honest, the actual statement that taking a certain number of tablets gives you an adverse health outcome has not been well studied, but there is some limited evidence, and I'll touch on that. The first thing is that the more drugs you take, the more likely you are to have an adverse drug reaction. So just a standard side effect. Fifth cause of death in the US, this is fairly old data, about 10% of admissions, as I've said. And basically, the more drugs you take, the more likely you are to have a side effect and have a consequence from it. So there's some basic sense there. And it is very common in my experience for people to consider a new health problem not actually being a side effect of the medication that they're taking, in the same way that we've talked about alcohol on the last speaker. Now, falling over. So this is, no geriatrician can work without having a slide of an old lady who's fallen over, because it's what keeps me in quids. So this is an old lady who fell over. Look, we know prescription medications are a risk factor for falling. There's a very large body of evidence. There's very few randomised controlled trials where drug withdrawal has been shown to affect falling, and that's because methodologically they're very, very hard to do. There is one study that has shown that not taking benzodiazepines does reduce your rate, not taking hypnosedative drugs reduces your rate of falling, which is perhaps not surprising. Very difficult. It's only been done once. It's a very good meta-analysis, and I know it's nearly 20 years old, but this was, if you look back in the history of falling, there was a lot of epidemiology done in the early 90s about falling as a clinical problem, and a lot of studies done on drugs and their relationship to falling back in the early 90s. Basically, there's a fairly consistent finding. If you take more than 4 drugs, you're about twice as likely to fall, or 2 to 3 times as likely to fall. And certainly some of the intervention studies one of their goals has been to reduce medications. It's not clear if this is, in this thing, is it only prescription drugs, is it over the counter, because they don't always count them the same way. One of the challenges we have is in modern pharmacology, to treat heart failure, you should be on 5 drugs. And yet none of the studies that show that those 5 drugs are good for heart failure have actually looked at falls as an adverse outcome, or actually studied all 5 in combination. And I think this is one of the challenges as a geriatrician we really struggle with, is that I am an evidence-based practitioner, but you have to interpret the evidence in light of the patient in front of you, and we have huge knowledge gaps here. Clearly the bad guys, and the ones that all geriatricians really don't like, are the psychotropic drugs. Having said that, we do prescribe them sometimes. And all of them basically increase your rate of falling. Not only increase your rate of falling, but for certain classes here will increase your rate of hip fracture. And it's quite fascinating, actually. I often see people, well, I don't do the falls clinic at the moment, but when I was, or I see people in my general clinic, and you'll be talking about their hypnosedative use, and I say, and I now say this, I know no doctor will ever have told you this before, but that increases your risk of breaking a hip by 50% or 40%. And they go, oh, no one's ever said that to me before. Still, even when I introduce it like that. And it's really interesting, actually. People have started on these drugs without the harms being explained to them, which I think is a very complicated ethical question. But they are small, but significant increases risk of falling. There are probably some confounders in that. So people who are depressed may be more likely to fall, and so there's a confounding by indication. But we do know that if you look at this, the risk probably goes up the more you take and the more classes you take. And certainly there is reasonable evidence to support that. It's not clear whether it's when you start the drug or on chronic use. There is evidence to support both. And certainly one thing to point out, it's commonly thought that the newer antidepressants, which actually aren't that new, it's obviously showing my age here, but the SSRIs are still considered the newer antidepressants compared to the tricyclics. They're all as bad as each other. Benzodiazepines are risky as long-acting. As I say, the newer antidepressants may not be any safer. And in fact, some studies have suggested the selective serotonin reuptake inhibitors, which is your Prozacs, your Zolofts, your Cipramils, may actually be worse than tricyclics. But that may be that people have been selected to be on those. In the meta-analysis, and it's interesting actually because I noticed people have said this, that opiates increase your risk of falling. In the meta-analysis published in 1999, where opioids were included and they clustered them all together, they didn't affect your rate of falling. Now that may or may not, obviously that's the epidemiology, understanding the epidemiology at this point, that's probably in lowish doses rather than when you're getting toxic side effects. Of the cardiac drugs, the interesting one is digoxin is the one that's the highest chance of making you fall, and antihypertensives, which is when I first started in geriatric medicine many years ago, we always used to worry about antihypertensives making people fall over, but they probably don't. There is a lot of debate in the literature. I've started off and started my career thinking postural hypotension was a really important part of falling over, which is a common adverse consequence of prescribing. I am not so convinced now. And I talked a little bit about the muscle mass before. One of the really unrecognised things in geriatric medicine is the impact that pharmacology has on your nutritional status. And loss of weight, which in older people, when you lose weight, in fact at any age, but it's particularly emphasised in older people, is you lose muscle mass and you start off with a pretty low mass. So if you diet an obese older person, which is in fact not recommended these days, what you'll do is you'll leave them with the fat and take away all their muscle, which is, if you think about it, not a great idea. Certainly the main current recommendation is to get into old age with a healthy weight range. And if you get to old age and you're obese, just focus on exercise and maintaining your muscle mass. And if you lose a bit of weight, that's great, but whatever you do, don't lose muscle. And we know muscle weakness is a risk factor for falling. Weight loss is it's a bigger predictor of disability. In fact, unintentional weight loss in late life it's a really bad thing for you, and it's not simply because it means you've got an undiagnosed cancer. It's bad for you for all sorts of reasons. And lots of drugs make you lose your appetite. All of the ones there are anorexiant, digoxin, SSRIs, perhexylene, amiodarone, metformin. I see it, thousands of drugs I see that cause people to lose weight. One thing that worries geriatricians is when our patients lose weight. One thing that doesn't worry other prescribers, and this is the interesting thing we talked about, the number of drugs versus the number of prescribers. You know, I often sit in the middle of all of this, and I'll have very irate physicians who say, how dare you stop those drugs? I sometimes actually don't tell them because I'm sick of being yelled at, but you know, sometimes you've got to try and look at the person in the middle, and if they're losing weight, you've got to worry about that because it's a very bad thing for you. All these other things can do it. And certainly antipsychotics, benzodiazepines, we know that antipsychotic use in people with advanced dementia is associated with increased risk of stroke and death, and that probably relates to effects on oral intake and swallowing. And certainly swallowing difficulties are a problem in very late or advanced dementia, and that is exacerbated by the use of psychotropic drugs, which adversely contributes to mortality. Delirium. This is what you get if you do a Google images on delirium, and I think for an addiction specialist is good because I'm sure that's some sort of advert for ecstasy, but I'm not entirely sure. Now, you said it to the Delirium Cafe in Belgium, but I couldn't find an image that suggested it was that. I did look up the Delirium Cafe in Belgium because there's apparently a cafe called Delirium in Belgium. I don't know if they sell ecstasy or not, but anyway. There's one in Spain. Everyone is the Europeans. They're obviously into it. So drugs and delirium. And this is, again, a thing we see. People are very vulnerable to this. And certainly drug withdrawal is a very common, and discontinuation syndromes. There's toxicity from serotonin syndrome, which is when you commonly a component where you take more than one drug at once. There are some non-psychoactive drugs that have it, and that can do it. One of the things we know is that one of the things that seems to drive delirium, or the severity of it, although the evidence for this is not as robust as you might like, is that drugs that have an anticholinergic effect. There's certainly a body of evidence to suggest that changes in acetylcholine levels in the brain are common in people in delirium. Probably what the epidemiology hasn't demonstrated is how much additional risk you get for being on those drugs, because some of the recent studies suggest that that may not be the case. We have a lot of drugs that increase acetylcholine or block acetylcholine in the brain. Acetylcholine is very important for memory, so it's one of the primary neurotransmitters we target with the currently available drug treatments for dementia. Obviously, there's a lot else going on in dementia, but it is bad for your memory. And there are lots of medications that we would routinely prescribe that actually probably have anticholinergic properties. And a common example of that is prednisolone. So a corticosteroid is a very common drug used in general medical practice. If you actually measure that in the lab, it has anticholinergic properties. Sertraline of the SSRIs has the highest level of anticholinergic properties, although if you look on the product information, it's not called an anticholinergic drug. And even frusemide has some anticholinergic properties, which is a common diuretic. And if you layer all those together, you probably increase the anticholinergic burden. And that's a segue, thank you, onto this discussion of drug burden. And I will move through this relatively quickly because the science is a little bit complicated. So this is none of my work. This is all Sarah Hilmer, who's a geriatrician and clinical pharmacologist from Sydney. And she created this thing called the drug burden index. And I want you all to memorise this equation. But essentially what she did is she statistically worked out a way of quantifying the number of sedative and anticholinergic drugs you were taking. And she did this simply on the basis of whether they were sedative or anticholinergic on the way they were described. So a benzodiazepine, something that has potent anticholinergic properties, not any of these subtle things I've been talking about. And she did this in Health ABCs, which is a study in America, and she got the drug burden index calculated from drug lists, drug bag counts, as they called them in these studies, a brown bag where they looked at all their medications, and measured functional measures, which we use quite commonly in geriatrics, and I'll explain those in a minute. And the reason why I think this is so significant, because they're not dramatic changes, and I'll explain in a minute. But basically, over the years, she took the drug burden index at the start and measured their physical function. So the thing that, I talked about that lifespan we go through, and that this loss of ability before we die, physical function, the ability to maintain independence is, that is the therapeutic gold we're seeking in geriatric medicine. We all want to live ably. And does taking drugs, these drugs, affect your ability with physical activity? And she was able to show that it does. I'll just skip over that. So basically, she looked at these, had a lot of, in these large epidemiological studies, a lot of covariates to allow to correct for things. They measured these things. These, for a non-geriatric audience, these are quite common measures. Gait speed's quite an important one. Short physical performance battery is one of the measures that's considered of how you can identify elements of frailty in a population. And grip strength is also a measure of frailty. So grip strength is a measure of muscle function, and it is associated with a poor outcome in populations. Now, basically what we can show is that there's an association with drug burden index and the fact that you statistically are more likely to have a slower gait speed. Now, that doesn't sound like much, but this is the first time we've actually been able to show that taking medicines affects your ability to do things. And we've suspected that clinically for a while, and these were healthy people. These are not diseased people, these are healthy people. And I think this is a really important thing to recognise, that drugs or prescription medicines can have unintentional consequences. She showed it for grip strength. Basically, she was able to show that for all of those performance measures, which are standard, well-recognised measurements of the geriatric literature, if you took more drugs, you did worse over time, corrected for all the comorbidities. And I think that's a really important finding, that we shouldn't be throwing these things around willy-nilly. Now, in closing, I'm going to make a few comments about substance abuse in older adults. Again, speaking from a position of not being an addiction medicine specialist. I personally think it has been very poorly studied, and I think you'll note, and I think Brian's work is the first I've seen of, we've really tried to look at in older populations. And it's not taught to us as geriatricians. We don't teach it to our trainees. We really don't know a lot about it. In my experience, benzodiazepine and alcohol abuse are really common problems. I don't see a lot of iatrogenic opioid addiction in very late life. Thank you. And I do know that, and I echo Brian's comments, and that dementia can predispose to alcohol abuse. It is a very common clinical scenario to see someone with early dementia whose the brake comes off their drinking. And often you can stop it by people just not supplying them with alcohol and an explanation. And they do forget that they've been drinking. And Brian's probably, again, shown, I think the first data show that there is evidence to support that. There is a relationship. The issues, however, one thing I would make a comment is that, in fact, the issues of physical and psychological and physical dependency are actually incredibly common in the population I treat. And I teach medical students a bit about appropriate prescribing, and I talk about frusemide junkies. Now, you might think, what the hell is he talking about? So frusemide is a loop diuretic, but I'll explain a very, very common clinical scenario I would see of I'll say older lady, and I shouldn't pick an older lady, I'll say older man, but it's usually older ladies, who will have venous edema. So they'll have old veins, their legs will swell, they don't look very nice, they might be slightly uncomfortable. They'll go to their doctor and they'll say, my legs are swollen. He'll say they're swollen, you're right, he'll push his thumb into them, they're swollen, he'll give them a diuretic, frusemide. It's a relatively safe drug. Now, that'll make their legs smaller, but of course it'll make them go to the toilet more frequently. But what will happen is they'll be going out to Bridge or somewhere and they'll decide to stop taking the frusemide, or they'll decide they don't need it anymore. But they'll get rebound salt and water retention because their kidneys grown tolerant to the presence of the frusemide. So their legs swell even more than they did before they took the drug. And they think, man, I need that frusemide. Look how terrible my legs are. And then they'll go through these periods of withdrawal and reinforcement of the need of the drug, so that when I see them and I suggest, really, maybe you don't need that diuretic. Oh, I can't take that. I can't come off that. The moment I stop that, my legs will be terrible. And I don't know if that's any different from what I was taught about heroin addiction. Seems to be the same thing. And yet that plagues, you can see it with proton pump inhibitors, because you get rebound acidity when you stop taking Nexium. You can get, and you certainly see it with the benzodiazepines and those drugs. So I think this issue of withdrawal and reinforcement is a really complicated problem and actually pervades prescribing in late life. And because we give them a lot of drugs, we create a lot of these cycles. So if I am an addiction specialist, that's where it comes from. So in conclusions, there are significant therapeutic risks in prescribing in late life. Nutrition, falls and cognition, the worst things, commonest adverse effects. They're certainly worse in misuse, and certainly alcohol is a terrible drug in older people, and we do see a lot of problems related to it, all of which have been described. And I think the problem we have is that these issues of physiological and psychological dependency are actually common in all forms of prescribing. It's all part of our drug-taking culture, really. And I've got a time's up with a smiley face, which is perhaps surprising. Thank you.